Hey, Mark Testa here. I'm in Broomfield, Colorado with Regenx founder and Chief Medical Officer Dr. Chris Centeno. And today we've got an exciting show. I'm excited to talk about, well, I'm not going to talk about it. Dr. Centeno is going to talk about it. Exosomes, what are they? Where do they come from? What can they treat? What does the research show about exosomes? What does FDA say? Dr. Centeno.
Yeah, thanks, Mark. So let's start with what are exosomes. Exosomes are how cells talk to each other. So you have a cell, pretty much any cell in your body, and if it wants to communicate with another cell, it can do that. And they float through the fluid until they get to the other cell, and they deliver their payload in the other cell. And that payload can be everything from a chemical to cause that cell to do something, to even little snippets of RNA to reprogram that cell. So it's how cells talk to each other. So stem cells also produce exosomes. And those exosomes tend to be involved in lots of different things, but including repairing tissue. And how that works is those exosomes can deliver the message to repair tissue. So the concept came up that maybe you can get rid of the stem cells and just take the exosomes that are being excreted by the stem cells and just use those exosomes. So that's the concept behind exosome therapy. The problem is that the reality and the concept are still pretty far apart. And what I mean by that is that let's take, for example, a contractor. Let's say you hire a contractor to redo your kitchen. And that general contractor goes and he hires a plumber, he hires the guy to bring the appliances in and hook them up. He hires another guy to do the countertops, another guy to do the cabinets, and he's giving instructions to all of those people about what you want and where it all goes and how it fits to the plan. Now, those instructions are just like a stem cell giving instructions through exosomes to the surrounding cells. Now, imagine if you tried to take what that guy said to all those different subcontractors, and you just used it on another job, and then another job, and another job, and another job. As you might imagine, it's not going to work real well because that contractor's got to come in, he's got to see your kitchen, he's got to figure out what appliances you need, where they go, how they fit to the plan. That plan's different than your neighbor's plan because your neighbor's kitchen is different. So that's the problem with just using exosomes without a stem cell involved. The stem cell is the general contractor that figures out which instructions. Again, the exosomes are the instructions to give. So exosomes without stem cells need to be dialed in quite a bit.
This morning it was very poignant to that point. And what do we need to do to dial them in?
You know, I think we will find, so the first thing you need to know about exosomes is that just like words, so I'm having a conversation with you and I'm going to use during this conversation probably at least 1,000 different words. And same thing with exosomes. There are at least 1,000 different types of exosomes. So we have this blanket term called exosomes, but they're different. They're as different as language. Because again, this is how cells communicate. So what we would need to do is we would need to maybe take stem cells and put them in a position where they were repairing cartilage, and then take those messages. And you can't just have the messages, you have to also have to time those messages exactly, meaning that the instructions that the general contractor gives when he starts the job are different than the instructions that the general contractor gives when he finishes the job or he's in the middle of the job. So again, all of that needs to get dialed in. And can it be done? Yeah, probably one day that'll be easily done. But that day's not today, regrettably.
So what does the research show about exosomes at this point?
Yeah, as you may have seen from my blog this morning, we have, as an example, if you look at knee arthritis, we have 26 randomized controlled trials on showing that PRP works to treat knee arthritis. So that's using your own platelets. We have 50 some different studies, 58 I think, on using bone marrow stem cells to treat knee arthritis. As of this morning, we have 0 studies on using exosomes to treat knee arthritis. So we got some research to do. The research isn't there right now. Hopefully it'll get dialed in the next 5 to 10 years, but it's going to take that long for the research to catch up to things like PRP and bone marrow stem cells.
So to take that even a step further, Blake asks, are exosomes dangerous?
Yeah, it's a good question, Blake. I don't think anyone has a clue right now. As an example, I showed 2 studies this morning where we had a scenario where the patient had certain elevated types of exosomes if they were going to be more but certain messages are not desired in certain situations, just like certain types of speech not desired in certain situations.
Yeah, interesting. How about, you've talked about host versus graft issues. Can that happen from exosomes?
No. On the surface of an exosome. Listen, I think right now I've been doing stem cell work since 2005. So in the last decade and a half, I have seen so many different things come and go. And it seems like every year there's a new fad. I mean, literally I could trace and then by this time next year, the exosome fad will have died off. Exosome product. So it's like, hey, we'll just change the name on this and see if that sells. And it's causing the sales to go up. So they're continuing to talk about it as an exosome product.
That's too bad. What's FDA say about this right now?
FDA so most people don't understand that FDA regulation has to do with the claims that you make. And the example that they give on their website is a really good one because it helps you understand it very quickly. So you can go out there and obviously sell all the charcoal you want to use to heat a home, to use to produce electricity, or whatever it is you use charcoal for, to use on your barbecue grill. Charcoal sold that way is not FDA regulated. Now, the moment you start making the claim that charcoal can be used to help in poisoning victims, now charcoal becomes FDA regulated. So it's the claim that generates the regulation. So same thing here. The moment you can sell exosomes all you want for research purposes, you can sell them to scientists to do research on, but the moment you start making a claim that exosomes can be used to help somebody heal something, it becomes a drug. And so FDA has been very clear about this. There's been 4 or 5 people that have pinged them, and they've all been consistent. All the messaging coming back for FDA says, if you want to make a claim that you're selling exosomes, whether you're selling them or not doesn't really make a difference. Whether they work or not doesn't make a difference. We're going to consider that claim to classify what it is you're selling as a prescription drug, and it requires full FDA approval for each medical indication, which none of these companies have. They've been registering this stuff as a tissue, which is a free 45-minute online registration.
That's too bad. Let's see. I've seen, and you probably have too, facial stuff with exosomes, hair stuff, all kinds of joint things. It's hard to, for lack of better words, sell this to consumers without making that kind of claim and saying that you're treating something.
Yeah, I mean, pretty much all of these companies make a treatment claim. So as soon as they do that, it's an unapproved drug product. But listen, long story short is, as an example, I was talking to Mark earlier. If you've had platelet-rich plasma, platelets produce exosomes. In fact, I'll be doing a blog here either tomorrow or the next day, showing quite clearly that PRP has got tons of exosomes in it. So if you've had PRP, you've already had an exosome treatment. Obviously, if you've had stem cells, you've already had an exosome treatment, because that's how both of these things talk. But the difference is, in both of those instances, you've got a sophisticated machine, if you will, whose job it is to detect what's out there in the environment, and then from that, issue the right command, just like that general contractor. But if we take that general contractor out of the mix, we've got a mess.
Yeah. Where do they generally come from, exosomes? How are they?
Exosomes can be, so as an example, you could take your urine and ultracentrifuge it, because these things are really small. You have to put it in a powerful centrifuge, and you can concentrate the exosomes. You can get them from serum. You can get them from cells that are growing. You can get them from amniotic fluid will have exosomes in it. Pretty much any tissue in your body has exosomes, because again, this is how cells talk to each other. So these are the words that cells are saying to each other.
Let's see here. We had a question earlier from T.O., and we'll take your questions. We can talk about other topics here today as well. What's best for a disc issue? PRP, stem cells, or cultured stem cells? You didn't exactly say what the disc issue was.
Yeah, it's a good point. It literally depends on what's going on with the disc. So if what you have is just a torn disc that is producing pain, then either PRP or bone marrow concentrate, which is same-day bone marrow stem cells, both of those work pretty well. If what you have is a chronic disc bulge, then that's more cultured stem cells. And the goal there is to try to get rid of the disc bulge. And then finally, if what you have is a severely degenerated disc where the disc has collapsed and it's just moving around too much, then we generally don't inject the disc at all. We inject everything else but the disc to try to stabilize that segment, and that works far better than injecting something into the disc.
How many discs would you treat at one time? I've seen people say they've had 4 or 5 degenerated discs with an intradiscal something or other, and does that seem excessive? 4 or 5 discs at a time?
Yeah, every disc that you inject has about a 1 in 200 chance of producing a disc infection called discitis. Discitis is where you get an infection in the disc that then requires IV antibiotics or that requires surgery. So if you inject 5 discs, you're just increasing that risk by 5x. So we try hard to stay out of discs if we can. I've treated 2 at a time, sometimes 3, but not generally more than that, because again, each and every time you're taking that 1 in 200 risk, so you need to be cautious with that.
Kevin asks, international patients for PICL are scheduled without DMX, and when they get there, they get the DMX here in Colorado. How are they determined to be a candidate for the procedure without the DMX?
Yeah, good question. For international patients that are from Europe, there's actually an imaging center in London that we've been using that doesn't do DMX, but they will do a high-quality movement-based MRI, and we can frequently tell from that imaging that the patient is a candidate. Other options would include looking at other aspects of their films, and or other things that we can order, like a rotational CT scan. So there are other ways to do it, but that facility in London has been a good one to look at for us.
That's great. Good question, Kevin. Thank you. Any other questions? We've got the expert here. Glad to answer them today. Now, you were just at our license site in Grand Cayman.
Yeah.
See anything interesting there? Or
we always see interesting patients down in Grand Cayman. We saw, I saw a patient who had Ehlers-Danlos syndrome, so we treated lots and lots of different ligaments in multiple areas. Saw many patients with severe knee osteoarthritis, treated a couple disc patients while I was down there, lumbar discs. One of the things that's different about Grand Cayman is that because we grow so many more cells there, we can treat lots and lots of different areas. So generally the procedures tend to be longer duration because we're treating more spots with stem cells. So, there are patients down there where I'm treating 3, 4, 5, 6, 7, 8 different parts of their body because they kind of want it all treated while they're down there, and I've got the ability to do that because I can grow many, many more cells.
Interesting. Hey, Nancy asked, where can she find a list of our current clinical trials?
Current clinical trials. So the open clinical trials, I can just tell you, there are 3, and 2 of them are almost complete. One is a randomized controlled trial for knee ACL. That's using bone marrow concentrate, so that's an ACL partial or complete non-retracted tear. That one's almost done. It might have 2 open slots out of 50, so it's almost finished recruitment. The second one is a randomized controlled trial for shoulder rotator cuff tears, partial and again complete non-retracted. Again, that one's almost done. It might have 1 or 2 slots left out of 50, but it's almost complete. And then the third would be the randomized controlled trial for craniocervical instability, and that one is finished a pilot phase and just started up again, and it still has 40 left to recruit. So that one's pretty early. So those are the 3 randomized controlled trials that we currently have open, and then we've got all of our published research listed on the website.
And the clinical trials are published there as well, right? On the website, I believe they are.
Yeah, they're there.
Yeah. Todd asks, what are the best ways to minimize PRP from not working?
Yeah, let's see. One of the things that we have seen through the years is that triglyceride levels, which has to do with genetics, activity, plus usually carbohydrate intake, high triglyceride levels seem to be associated with platelet growth factors that don't work as well. Now that could be due to the triglycerides themselves. We're not 100% sure yet. But so fasting before you do the blood draw can be a nice way to mitigate that. Also, eating clean. And a third thing would be trying to get off as many medications that could be problematic as possible. So for instance, ACE inhibitor blood pressure medications we've seen problems with, or antiplatelet drugs obviously impact the ability of platelets to do what it is they do. So those are 3 things that you can do.
Good ones. Charlotte asks, she saw an ad where someone said exosomes were more powerful than stem cells. Now,
yeah, it's a little bit like saying the orders that a general contractor barks out are more powerful than having the general contractor. Again, doesn't make any sense at all. This is just someone's perception of reality that they got from the guy that was selling the exosomes. Again, realize that exosomes are the language that a stem cell uses to communicate with other cells, just like a general contractor would communicate with subcontractors. So again, exosomes are more powerful than stem cells is like saying, well, if I just take my phone and I record what the general contractor is saying, and I repeat that over and over on other jobs, that's going to be more powerful than if I had the general contractor there. Doesn't make any sense, right? The general contractor would need to be there to see what the job is, which subcontractors need to be hired and when, to get all of it done. So it doesn't even make any common sense if you know what an exosome is.
Kevin asks, in what case is a patient able to skip the posterior cervical injection and go straight to the PICL or get both done at the same time?
Yeah, we would only do that in rare instances when we have high index of suspicion that the person is likely a good PICL candidate, and there's some hardship reason why we can't do one, wait, and then do the other. So one hardship reason might be that the patient's traveling from far away. Another hardship reason might be financial. It's not going to work for them financially. So we have done that, but we want to make sure that that patient sounds like they're a very good fit for what it is we're doing with PICL. So they have the perfect story. The perfect story would be somebody like a gentleman from the UK that we treated who was playing rugby, fell on his head. From that moment on, he had upper cervical symptoms. All of his imaging looked like he had an upper cervical instability. So that kind of story obviously fits very nicely with the ligaments got stretched, and that's what's causing the problem.
Precious had an intradiscal injection about 6 weeks ago. How long is it to continue to feel some discomfort?
Yeah, generally for intradiscal injections, I always tell patients that can be a good days, weeks, or even 1 to 2 months. Probably the longest flare-up I've seen from an intradiscal injection is about 6-8 weeks until the patient turned the corner. If you're still having significant increased pain from the procedure, that's when that discitis issue needs to be ruled out, meaning that 1 in 200 times there are small amounts of bacteria that live in these discs, and if you stick a needle into them, that can stir up that hornet's nest, if you will. So that's, again, not likely. It's just 1 in 200, 0.5%. But one of the things that makes us think that is if the patient isn't getting better with time, or the pain isn't going back to what it used to be.
Todd asks if we know of any imaging centers in the Bay Area that can do DMX.
Yeah, Todd, there probably are. If you just go, what I would go Google right now is DMX Works. I think it's DMX, WORX. But just, you can also Google DMX Machine, DMX San Francisco, DMX Bay Area. The DMX Works company is out of Tampa, Florida. They're the folks that make the machine, and they generally know who has their machines. But oftentimes, the folks that own them have a good presence on Google and the search engine. So you could literally just type in DMX Bay Area. It's a pretty standardized protocol, so most of them that we see are pretty good quality. I don't have anyone offhand that I know of off the top of my head, however.
Todd also points this out. Blue Cross of North Carolina seemed to release an approval of amniotic membrane treatments under the plan they cover. They've issued procedure codes. That's what I call a Creative Coder Award, and it comes with an orange jumpsuit and a new boyfriend named Rick. What I mean by that, that's an oblique reference to meaning that the provider can end up in federal prison. So listen, if I submit the right code to any insurance company, that insurance company will issue payment. The problem is I can also issue fictitious codes that don't actually describe what it is I'm doing. So when it comes to amniotic membrane, the only thing that's covered by anybody is the use of that either in surgery for things like, let's say, patching the dura, or for eye surgeries. So unless I did an eye surgery, or unless I did a surgical patch of the dura, that membrane's not covered. Now I can use those same codes that would be for those procedures
and send it in, and it'll get paid. The problem is, if I ever get called on the carpet for that, that was an illegal payment. So many states have laws that would hold you to the Medicare rules, which means that you go to federal prison or you pay them back all that money. Well, what's going to happen when they find out the provider's doing that is that you're on the hook for that bill. Meaning that at the end of the day, that provider is going to have to write a several $100,000 to a several $1 million check to Blue Cross Blue Shield to reimburse them. And where do you think he's going to get that money? He's going to get that money from your bank account because you signed a little paper when you walked in that said if your insurance company ultimately doesn't cover this, you owe him that money. So don't get involved in any of that stuff. It's a total mess. I could get anything covered tomorrow. I could get bone marrow stem cells covered tomorrow. I would just call it a bone marrow transplant.
Right.
The problem is I'm not doing a bone marrow transplant. So at some point, they're going to come after me, which means I'm going to come after you. And that's how that game works. So don't get in the middle of that game.
So yeah, while Blue Cross may have issued a code, it's for surgery or
It's the reimbursement of amniotic membrane only when that surgery occurred.
Right. Let's see. Johnny had an L5 S1 discectomy a while back, re-herniated, having some leg pain. Would you recommend stem cells or platelets into the disc? I don't have anything else on that.
Yeah, so disc herniations are interesting. Frequently, they will resolve very nicely with just epidural, meaning not into the disc, but around the nerve, platelet lysate. So that's what I'd start with, meaning if this were my brother and he had a herniated disc, that's what I would do first before entering that disc. There are rare cases that we need to inject into the disc to treat that disc herniation, but generally if you just inject it around the disc, which is epidural, it's much safer, much less invasive, and it's likely that the body will clean up the disc itself.
Todd, thanks for sharing that link. I'm sure we'll take a look at it after this, the Blue Cross, North Carolina. Let's see. Precious asks, how do you rule out discitis?
Yeah, the biggest way to do that, Precious, is an MRI. An MRI will show that the bones around the disc are swollen, basically. And they'll, instead of looking dark on a certain type of MRI image where water is bright, they'll be bright white. And that's how that diagnosis is made. So an MRI would be the thing to do. Again, I would only be concerned about that if someone was still having significant pain from the procedure at more than 6 to 8 weeks out.
No fever, nothing like that?
Yeah, I mean, patients can get sick as well, but normally with this kind of discitis, where you stir up the hornet's nest, the patient generally doesn't get very sick. They just get pain. Now, that's different than, for instance, with the Livion debacle, which is umbilical cord, quote, stem cells, where they injected bacteria that was in the product into the disc. And those people got really sick really quick, within days. I mean, they were in the ICU within days. That's very different than this type of discitis where you put a needle in there and you just stir up the hornet's nest.
Let's see here. Randy asks, are there any clinical trials that you can't wait to see the results from? Maybe something that really intrigues your curiosity in the field.
Any clinical trials? Yeah, I mean, there are. One of the things that really intrigues me right now is we have, as of last month, we had 66 randomized controlled trials that have been published for PRP. In the last couple of weeks, there's been another 3 or 4 published. So the rate of publication of PRP randomized controlled trials now seems to be several a month. So it's that's probably the thing I'm most interested in because, you know, if you look at having that number of randomized controlled trials for any specific therapy, that's pretty epic, meaning that we don't have 66 randomized controlled trials on any surgery that's ever been devised by man. Certainly not how these are put together against other therapies that are conservative or placebo or sham. So that's probably the thing I'm most excited about right now is seeing all of that high quality publication coming out. Same thing with bone marrow stem cells. We're seeing new randomized controlled trials being published all the time.
Yeah, the PRP stuff is cool because, like you said, it compares it to steroid, hyaluronic, all kinds of different things that we've not really ever seen too much of before.
Yeah, placebo, etc. So interesting stuff, and we're in an interesting time moving from this stuff as voodoo to maybe this works to, well, it probably works, but we don't have the data on it yet, to it works and here's some good data.
All right, well, listen, any other questions, any final questions? We're glad to take those. This is great, great insights on exosomes.
Yeah, listen, at the end of the day, I think the field of exosomes and extracellular vesicles has some real merit, and there's a lot that's going to be published and a lot that's going to get dialed in over the next 5 to 10 years. I do think, though, that the folks that are, quote, selling exosomes in a vial and promoting exosomes as magic pixie dust are putting the cart before the horse. And we don't know how to dial this in yet, and we won't for quite some time. It's not like you put a stem cell in there and the stem cell has intelligence and knows what to do. That's very, very different than just throwing in the exosomes where there is no intelligence on what to do. So that's the problem.
That's the mic drop. All I can say after that is we'll be back next week with some more topics on regenerative medicine. So if there's something that we haven't covered, please let us know, and we'll be glad to get to that. And thanks for tuning in.
Thanks.